This morning, I have the pleasure of introducing Dr. Carter Lebares, who is our own from the Department of Surgery. Some of you have seen her help us with some of our cases on Team Gynonc, and we're truly appreciative of that collaboration. More importantly, Dr. Lebares is the vice chair for the American College of Surgeons Committee on Surgeon Wellbeing. And as that area of discussion, we in the Gynonc division thought it was really important for her to come and address our department in the grand round setting. Dr. Lebares is an associate professor of surgery. She's the director for the UCSF Center for Mindfulness and Surgery. She hails from, actually, where do you hail from? But
Minnesota.
I was going to say she went to school in Minnesota and did her MD there, and then came here for the training, and then also did training in Strasbourg for minimally invasive surgery. Her research focuses on stress and resilience in surgery and factors that influence surgeon well-being. And based on this, she's created a mindful intervention called Enhanced Stress Resilience Training, and is part of the Academy of Master Surgeon Educators, which is a great honor in the American College of Surgeons. So thank you for coming, and I look forward to hearing your presentation.
Thanks, guys. Can you hear me okay? In the back, which is where most of you are. Good choice seat selection. That's what I would choose too. Okay, these are my objectives. We'll go through those quickly. So a little bit about this Wellbeing and Surgery Collaborative. This is a new joint venture between UCSF and UCLA, our departments of surgery. My counterpart at UCLA is shown up there in the corner. That's Ronnie Sullins. She's a pediatric surgeon. I like this better than her professional shot because she's wearing Star Wars headgear, which shows you a little bit about what she believes in. And she just operated on that teddy bear really just to make a patient happy. So she's a pretty committed person. And so am I, especially in this particular area. And what we've seen as research in well-being in surgery has grown. And by surgery, I don't just mean general surgery, I mean all of surgery. And I also don't just mean surgeons, because we all know your day can be made golden or made crappy by all the people that we work with. And so this really pertains to all of us. But I use the word surgery and surgeons a little bit interchangeably. We're aware that there's not a hub for people to come to for evidence-based direct interventions. And there's not really a center of gravity in this field for studying and developing and collaborating on interventions. And that's whether they are on an individual, a systems, or an institutional level. Oh, hello. Okay. Not sure what happened there, but I'll keep talking. There's also not really a place for formal scholarship in this area. So if someone wants to design a study, if somebody wants to know what measures are out there, what people are sharing, how we are measuring complex systems, which can't really be measured through linear types of tools, isn't really place or people to go to try to find that information in a precise way. And then finally, we want to be a place that helps them. I think that's an area that surgeons increasingly get to. I'm just going to keep rolling. Okay, so when we conceive of what it is that needs to be done in this field, we think there's kind of three major things, three major gaps, if you will. One is, how do we manage what's going on with the ethos of our profession? And by that, I mean, how do we continue to sacrifice for strangers in a way that we can do survivably? The second thing is, what do we do about the well-being of ourselves and our colleagues? And so to put that in another way, how do we not become the sacrifice while we're in the process of sacrificing for strangers? And then the last thing, what do we do about the health of our patients? How do we protect what's sacred to us, even as the system around us and the larger pressures that are at work are constantly changing? And not to be a downer, but in many instances, changing for the worse in terms of putting patient care first. So let's start with number one, ethos of surgery. So actually having an ethos among a group of people is really important. There are studies predominantly coming from the military and then underserved youth populations that run in gangs, showing that strong sense of belonging and a shared identity in a group actually gives individuals a second layer of resilience. And so this synergizes with their own individual resilience. So that's one of the reasons why the ethos of the military is so entrenched and so promoted, is because they understand that the individual survives better when they can identify with the group. So, like these 7 virtues of Bushido, which is the ethos of the samurai, these types of qualities tend to be aspirational. They're things that we want to aspire to, that keep all of us sort of aiming higher. And in surgery, much work done by Carol Ann Moulton, who's at the University of Toronto, has identified many of the characteristics that are repeated again and again in surgeons. And so these are great things, right? These make us proud. And maybe all of us aren't all these things every day, but most of us are many of these things all the time. And that's fantastic. And that's part of what helps us identify and meet the qualifications of being in this profession, this vocation. And we know that we have a positive influence on the culture around us. So this can look like our sense of being disciplined, really promoting people's confidence in our dependability, or the fact that we're resilient can often inspire other people to look on the bright side or try again or work harder. But there also could be a negative influence when we are in a toxic or unhealthy environment where us being assertive can come across as bullying, and where when we're so resilient that we're unrealistic about our own needs, or when our desire to be so driven and so focused ends up leaving us isolated. So this leaves us in a place where we can agree that dismantling the negative elements of our culture is critical, but how do we preserve its heart? And so the $10 million question is, how do we help ourselves do really hard work and survive or even thrive while we're doing it? Because the fact is that much of surgery, intrinsic parts of surgery, are really hard and are never not going to be hard. So for instance, this figure here shows resources and demands. And this actually comes from empirical work, but these are also kind of no-brainers, right? Some of the demands of what we do, the things that drain us, drag us down, include imposter syndrome or loneliness. Those are things that are internal to us. I can't fix necessarily your loneliness or your imposter syndrome, but there are things that we can do to support that. The red bricks are the ones I want to draw your attention to, surgery being high stakes and time pressured. These are very stressful experiences, and yet there's no way to extract those from surgery. And arguably, if one is doing surgery correctly, there are some stressors that we should feel. And we know when we look at things like the first trial, for those of you who don't know, this is a study that was done in 2015, which included more than 50% of all US surgical residents in general surgery and more than half of the general surgery programs in the country. And it looked at flexible versus strict duty hour limitations. And this was at a time when duty hours had really just become strictly enforced, and so they were very rigid. The flexible group was allowed to stay long if they were in the operating room, and were allowed to come back to work the next morning with a shorter interval. And what they found was that those residents in the flexible group had no difference in major patient complications or in the quality of their education or even in their well-being. They were, however, less likely to leave an operation in the middle, and they felt more confident in the continuity of their care. And we know, even from a macro system level, that when we have more handoffs, when we exchange patients between groups, whether that's on the floor or in the OR, we introduce an increasing possibility of making errors. So before we start talking about throwing out duty hours altogether, I want to make it clear that that's not my premise. But what I'm saying is we've sort of jumped to one conclusion, right? We're overwhelmed. We're feeling like we can't function at our best. And so the one thing we can think to do, black and white thinking, is work less. But we're not in a black and white or a simple system or a linear answer kind of situation here, and I'll come to that. So the last thing I want to say that I think is just interesting is that we also know that burnout, depression, a lack of physician well-being does affect people's functioning. And it does increase our sense of having made errors, even though, and this is just a study with practicing surgeons from various specialties, kind of demonstrating a sense of increased perceived errors as their emotional exhaustion increases. But also we see in other studies, for instance, this comes again out of the first trial, where it was made clear that residents who felt more burnout had an increased odds of reporting a near miss, which was 1.8-fold higher, or an increased odds of reporting an error that actually caused harm, which was 2.71-fold higher. And yet, when they compared this data to actual misquip information coming out of these programs, and I can tell you later about how they managed that, but it's actually pretty slick. They saw no objective associated worse errors in programs that had very high quartile scores for burnout. So it's a little bit of a creative study design, but I think the point is interesting that people feel they're making errors, and our patients report feeling when they're with more burned out physicians and surgeons that they have less connection, that the physician patient bond doesn't feel as strong or real. But somehow we're still managing, even while we're burning and our patients seem to be kind of burning along with us, to not harm them with our medical decision making. And I think that's a really interesting point, because as we study this issue, we have to think carefully about, are patient outcomes really going to be the thing that shows us the seriousness and the effect of what's going on here? It might very well be that we will work and burn before we ever let that fall. And when you talk to families of physicians and surgeons who have died by suicide, that's often the experience that they describe leading up to those events. So sometimes the question is raised, is this thing that's putting our ethos of surgery into conflict or struggle something to do with generations? And in fact, the data doesn't really support that. So this paper that came out of the University of Washington in 2023 did a number of semi-structured interviews with what they called older generation and younger generation surgeons. And essentially what they found that was, while younger generation surgeons prioritized professional well-being more, and older generation surgeons prioritized more professional service, their ultimate priority, unprompted, interviewed separately, was again and again patient-centered care. And then we also see in a study from my group that just was published last year, that when we ask incoming surgery residents, and this isn't just a general surgery, this is all comers, we solicited incoming people designated to any type of surgery, what they expected versus what we hypothesized or knew were the potential demands that they would actually face, we found that they actually really expected substantial challenges. They were wide open that it was going to be super hard. And they actually expressed wanting to be transformed through that effort. And they expressed a really strong desire to belong to an elite society. So that doesn't sound like a group of people who are coming into these professions wanting to turn it into a 9-to-5 job at the Gap. That sounds like people who have like manned and womaned up, or whatevered up, whatever gender identity you have upped, and decided they want to do this job with everything that they have. What we did find, which was important, was that they very mistakenly assumed that they would be able to survive this experience alone, just through their own capability and gumption. And we posit that that is not possible. And so we need a different way of thinking about what to do about how to manage surgery, how to manage a career in surgery. Right now, we're using machine thinking, which is all lose, win, black, white, on, off. And where we're using this is by saying it's all or nothing. Either sacrifice yourself or don't be a doctor. And we need a different way to look at this. In fact, we know that healthcare and the experience of practicing in healthcare is a complex system. And this is a Stacy matrix. And when we look at how this idea of complex systems is depicted in this figure, it really helps us understand how complexity emerges in the process of trying to determine agreement and certainty. And on the y-axis is agreement, on the x-axis is certainty. And complexity emerges when these things diverge. And so as things, when agreement over what is needed and certainty over how we get there don't match, we're in very complex territory. And so in the example I just gave, say between generations, perhaps younger generation surgeons are thinking, I'm not going to work myself to death. This is stupid. You know, I'm watching you guys do this and it's nuts. But older generations or surgeons are saying, but we have to be of service. We have to dedicate ourselves to this work. So those things aren't mutually exclusive, and machine thinking would have us think that they are. They're actually just an agreement that the heart of surgery and the priority of patient-centered care is very important, but then uncertainty, not shared certainty over what we need to do to get there. And so what that means is that we need to invoke systems thinking, not machine thinking, not linear thinking, but systems thinking. And every biological system that we study, every human system that we study, whether that's the stock market or the weather, we know that to really understand how something works in a way that truly is really affecting us, not just the way it's written about in some book from 100 years ago, but the real experience of how things work is not linear. It's either a spiral that moves forward in time. So like, oh, dang, I'm doing the same thing I used to do before, but I'm a little bit better at it. Or it's a network, for instance, in the brain. And so systems thinking enables you to grasp and manage situations of complexity and uncertainty in which there are no simple answers. It's a way of learning your way to effective action by looking at connected wholes rather than separate parts. And so to keep that from being too abstract, I'll just say that there's 7 principles involved in complex adaptive system thinking, and they involve these 7 things you can see here. And just to kind of give a brief example of what those mean, for instance, adaptability, this means that the parts of any system you're looking at can change and can change themselves. And if that sounds wild and crazy, just think about when you learn. You are changing yourself. So it's acknowledging that every part of a complex system can learn, can become different. Also, that change is not linear. So a small change can have a big effect. And so I would just encourage people to think about when we imagine the way healthcare is structured right now, like, oh my God, it's such a big problem, there's no way we can fix it. It doesn't work that way. Small changes can have big effects. So small, really great ideas. So imagine like a rumor gets started. It can cause unionization. And I'm not promoting that or discouraging it. I'm just saying that's a process that we see exist. The third thing is continual creativity, which is just another way of saying things are in evolution. They're constantly changing, which makes them unpredictable. And what that means is that we need to observe these kinds of processes and instead of trying to predict or diagnose or forecast where they're going to go or what they are. And that there's inherent order, so that even without top-down control, there actually can be order in complex systems. So for instance, like termites, they manage this incredible feat of being these minuscule things that very systematically grow these giant towers of dirt. And there's no CEO. And then the systems are always embedded in systems. So what this means is that while we're looking at the issues that we're trying to deal with here in our own environment, we have to be aware that there's a bigger system in play. And where that I think pertains to healthcare and how we think about our work and what we need to do in order to make our workplace more healthy, it means that we have to bring our leadership on every level to the table. Not as a capitulation, but as a collaboration. So I would just want to give a quick example of this. This is a study that we're doing right now that stemmed out of some work at Parnassus between the Department of Surgery and the Department of Anesthesia. It's kind of a neat study design, which I won't go into much length here. I put the red arrow there just because AI chose these 3 figures for OR efficiency, what motivates and what inhibits, and I was trying to figure out what that bottle of pills is. Opiates, I don't know. In any event, this study was prompted because when we asked people what their greatest pain point was, it was OR inefficiency. Now, this is just at this site, but that's actually been noted as the greatest pain point among surgeons at multiple sites and in multiple different countries. So it was OR inefficiency, and we looked at all of the efforts that were being done to fix OR inefficiency. And so when we talked to people, we heard a lot of can't be done, can't be fixed. We've been trying to fix this for decades. It's just part of life. We looked at the data. There's lots of dashboards and minutes and punitive stuff. Your dashboard now is red because you didn't sign in on time, or someone's going to send you an email because you didn't fill out one form and click 2 buttons. And none of that's ever worked. The OR is just as inefficient as it was 15 years ago when I first came here. It is today. So we thought maybe we need to employ some different kind of thinking about this. And so taking these complex adaptive systems and systems level thinking principles to heart, we decided to observe what exactly we were seeing going on. And when we were in the OR and we were watching and listening, we noticed that of all the other players that are in the room, scrub techs, circs, anesthesiologists, or CRNAs, even our residents to a degree, there's like a dead spell. There's something that happens around 1 o'clock. And if you don't start your case before 1, like your third case of the day, you're not going to start it till 3 or 4. Why is that? Right? So instead of trying to predict what the reason was, we started to ask. So we started to conduct interview after interview with people representing each of these groups, both at Parnassus and at Bayfront, right? Where it can actually be quite different. People can really be in it to win it, and we're all a team. And as we did that, we started to discover that among CRNAs and scrubs and circulators, and I'm not singling them out, I'm actually kind of celebrating them for taking care of themselves. There's a system where they are not rewarded for being efficient. What happens is if they finish their room before that witching hour, they get put into someone else's room at the end of the day. They don't get to finish their cases with you. And usually the room that they get put into is the super stressed surgeon who has an emergency case and so is kind of a butthead, or it's someone who's already a butthead that no one else wants to work with. And so that's their punishment for hustling through the day and really helping you get home in time for dinner. So I asked them, what would you need to just stay in it till the end? Like, what would that take? And I'm embarrassed to say, I said, what about more RVUs? What about money? And they were like, and I said, okay, well, what about like a gift certificate? You know, the team can go out to dinner. And they're like, eh. So then I said, okay, well, like, what would it really take? What would you want? And I said, what if we could be with a dedicated team? Because when we go into those other people's room, they make us feel stupid. Like, I've been doing this for 20 years and they make me feel like don't take my job seriously and like I'm a dummy because I'm an eyeball circulator who's being asked to do spine, right? And that makes me feel dumb, and it hurts my feelings. It hurts my sense of my professional value. So I'd like to be with nice people. I'd like to have a team I can depend on. And if I do really hustle through my work and do a great job, I want to go to the good room. That's what I want to be rewarded with. And so it's a completely different set of rewards. It's a system that we weren't thinking about in the correct way. And this allows us to transform this situation. And we'll see if that transformation actually works, but at least now we understand what we're working with. And our next step will be to see where we can take that. So that is just an example of how we can change how we think to approach old problems that we seem to think we cannot solve and find new ways that actually seem manageable to do what was previously felt to be impossible. And I think we need to bring that kind of thinking with those kinds of tools to the problems that we're facing in this area. So in terms of not becoming the sacrifice, this was kind of the second thing that we thought was really important in well-being and surgery. We know that all of these factors that have been associated with, are connected to burnout and all of its downstream negative sequelae are mediated through stress. And I'm not going to go through the body of research here that demonstrates that, but it's growing and it has some really wonderful studies that demonstrate this to be true. And because of that, this is also a shared opinion by the National Academy of Medicine that having individual level interventions is actually really important in this climate because the individual is the lens. And we either amplify for good or ill the systems that we're experiencing, the culture that surrounds us. And that really helps determine in a large way what the outcome will be. That's important, but sometimes I think that that suggests maybe the onus is on us. And so the way I think of it is when a patient comes in with sepsis, we all know what it takes to fix sepsis, right? Source control. But we don't stand there and do nothing while we wait to figure out the source to control. We give them broad spectrum antibiotics because we know that increases their odds of surviving this calamity that they're experiencing. And so I think of individual interventions as antibiotics. You know, doesn't solve the problem overall, but it helps us not only participate in the solution, but get to a point in the future where a solution exists. So with that kind of thinking in mind, and based on research in numerous high stakes, high pressure fields, in like the military, elite athletes, hostage negotiators, police officers, we developed a mindfulness-based intervention. It is cognitive training. So while it incorporates things like Qigong or yoga, it is really training your mind. And it's training your mind in 3 specific skills, which is your attention and awareness, your ability to recognize and not react to your emotions, and then your sense of metacognition, which is your ability to have a perspective outside of just your own small individual perspective. And these are kind of the specifics of what we do, 5 weekly 1-hour classes. And I'm not really going to delve into all that this involves, although I'm happy to talk about it anytime. But we've run 2 small randomized controlled trials at UCSF using ESRT. This is from our second randomized trial, which actually included residents from OB/GYN and emergency medicine and several other subspecialties of surgery besides general surgery. And what we found was that the orange line, which represents the intervention group, the ESRT group, that they had lower emotional exhaustion, lower depersonalization, which seemed to increase, that benefit seemed to increase over the 6-month period that we followed them. And this was just after the single 5-session course. So it showed us that this does indeed address burnout. We also looked at neuroanatomic changes because we wanted not just some self-report measure like burnout, but we wanted some true objective evidence. And so we did functional MRI, and we looked at, in particular, resting state functional connectivity, which is the term for increased myelination and increased axonal tracts between 2 parts of the brain. And so going back to that original idea that you can't understand something just looking at its individual parts, that really the nature of a thing is derived from its connections, its networking. The brain is one of the perfect examples of that, right? Like, looking at the brain is just like a bowl of fruit. There's an apple and there's a pineapple. We were not understanding it at all, where actually it's like a fruit tree. And so we need to know what's connected to what. Where does it hang? When does it work? How does it light up? Who lights it up? And so functional state resting connectivity is one measure of that in neuroanatomic imaging. And we chose, in particular, the connections between these 2 parts of the brain, the dorsolateral prefrontal cortex, which is the widely accepted seat of executive control, driving things like creative thinking. And then the precuneus, or the posterior cingulate, which is widely held as the seat of self-awareness and also motor memory. And these were a priori areas of interest and a connection of interest because of some data we had seen in a much earlier pilot study. And so what we found was that in the ESRT group, represented here in red, there was a 21% increase that grew, that evolved over that 6-month period, increase in functional resting state connectivity, or actual myelination of the axons between these 2 sites after taking 5 1-hour courses of ESRT. So to put that in a little bit clearer language, there was a lasting neuroanatomic change, increasing the functionality between these 2 critical parts of the brain after taking this class. And when we looked within individuals, we saw that increase in functional connectivity predicted decreases in circulating pro-inflammatory gene transcripts, in particular those for the fight or flight signaling cascade. And when we looked at higher pro-inflammatory gene expression, we saw that it predicted higher self-reported stress. So they took a 5-hour course, had lasting neuroanatomic changes in their brain that correlated with less physiologic stress, less subjective stress, and less reported burnout. And so studies like that have prompted more studies across the field showing that mindfulness training, particularly in surgery, these papers are, the majority of them, just about surgeons, improves professionalism. It improves performance. This is a study with neurosurgeons using a simulator and looking at complex technical tasks. This is a study looking at practicing surgeons actually in the OR and their experience of stress versus flow. This is a study that is not in surgeons, but in combat pilots, which I just think is really exciting because it shows us that we can also try and study the effects of these things literally and really on the job in very precise ways. And what they found was that a similar mindfulness training to ours resulted in much higher emergency responses with much greater proportion of positive outcomes, both micro and macro system outcomes, after training in mindfulness versus controls. And then we've also seen it improves career trajectory. This is a study from the UK that used our intervention ESRT, followed up residents after 2 years and saw that they continued to have less burnout and less stress, and that those who had taken ESRT were 13-fold more likely to obtain top-tier placement for advanced fellowships. And so why does ESRT or other types of mindfulness interventions do all of these great things? It sounds a little bit unbelievable, but we think the reason is because the stress response is universal. So it doesn't really matter if you're receiving an award and walking up in front of the decision team, or if you're about to get a parking ticket or have a cop in the street. Your physical reaction is exactly the same. Dry mouth, shaky hands, increased breathing, rapid heart rate, because your body doesn't really know the difference. And while that kind of sucks because it means we're getting stressed out during the day, maybe for some things that aren't really necessary for us to get riled up about, the beauty of it is that this shows us there's a process at work. The brain takes in information, the body reacts, and then we don't do the same thing for both events, right? So if someone scary is walking behind us and we're going in to give a talk in front of a bunch of people, in one instance we run away, and in the other instance we walk right in. And that's because something happens going back this way to inform the brain that things are okay, a pause, if you will. And it's exactly at that spot where we believe mindfulness training works. And this is why it can be so widely applicable to so many different things. It's really a core process. So this is how we're envisioning helping to protect our colleagues, and certainly the green box with ESRT in it could be any number of things. It doesn't just have to be this. It can be other types of interventions, but we do need to have something. So then very quickly, the last thing I want to talk about is how we protect what's sacred. And I think the most important thing for us to be thinking about in this area, how do we protect our patient-centered care, is to be aware of and thinking about the growing influence of private equity in healthcare. This is a really excellent publication that details some of the best data we have to date, and it comes out of the Petrus Center at UC Berkeley, and it's freely available online. But what we do know from places like the Petrus Center and Bloomberg School of Public Health is that private equity has poured nearly $1 trillion into 8,000 healthcare transactions during the past decade, and this is only increasing. In 2021 alone, it was $206 billion, which is one of the most recent years we have the best data from. And we know that the ownership of private hospitals in some states is strikingly high. So private equity ownership of hospitals in these noted states can be a fifth, third, almost half. And that's worrisome for reasons I'll explain in a minute. But we also know that the private equity influence is not just limited to for-profit hospitals. This is a study that looked at nonprofit hospitals. It took 15 of the large nonprofit urban academic hospitals in the country, and it looked at the composition of their governing boards. And they saw this breakdown of the types of people that were part of the governing system. And when they explored deeper what it meant to be in the financial activities sector, it turned out that 80% of those people actually were CEOs of private equity funds, wealth management firms, and multinational banks. Yep. And those are our decision-making groups. So I think it's really important that we know that. And so if we go back to the very beginning of this, where I'm talking about how we have to think about all the parts in the network, bring all those different stakeholders, if you will, to the table if we're going to solve these problems, it really means this is something we need to think about and engage in. And then probably the last and most important reason is because there's more evidence coming out now that as hospitals become private equity owned, there's an increase in complications. For instance, 27% more falls, more central line infections, and a doubling of SSIs. And then in this very recent paper that just came out, it's showing that the patient care experience continues to decline on a curve as the ownership by private equity continues. So to wrap up, there are a lot of things at stake. They're really important. This collaborative wants to be a place where people can come, find tools, get measures, get help connecting with people across the world who are trying to address this issue, help us work together to find funding, and share this space. One of the things that we want to do with this collaborative is to change the practice of academic research being a pyramid where you pick everyone who gets close to you at the top off. We really want to bring people in, recognizing that this is going to have to be done by a lot of people coming from a lot of different perspectives. And the good news is that there are people thinking ahead. So I'll leave you with some hopeful notes. The idea of workplaces evolving is being put out there. This is from the US Surgeon General, envisioning the workplace as engines of well-being, showing workers that they matter, that their work matters, and that they have the workplace resources and support necessary to flourish. So as opposed to being a place where you go and then recover from when you get home, your workplace could conceivably be somewhere that helps grow the very well-being that we're thinking, that we're striving for. This isn't crazy. There's funding out there for things like this. The AHRQ for the first time in 2024 put out a call that didn't ask people to link physician well-being to patient outcomes. It baseline acknowledges that and says instead, do research on systems to promote physician well-being. And this is a first of its kind, and it's a large grant. And then finally, be involved in the solution. So whatever solutions we come up with, the best ones are going to come from us. If the people on our governing boards, as we saw they are comprised, are making up the solutions for what's going to make our lives better and this work more human-centered, they're maybe not going to come from the same perspective as us. But none of us make good decisions when we're furious or demoralized. So this is another argument for equipping our brains with cognitive skills to help us do our best thinking. And then the last thing I want to say is, in terms of the antibiotics for sepsis, for us protecting ourselves, this work can often feel like we're 10,000 feet below water, and we're holding our breath, swimming at the same time. It looks like this person actually has a spear gun or something as well. Maybe you're struggling with a riptide, and it really can feel like both, it's amazing I can do all these things, and it's amazing I have to do all these things, both at the same time. But what I want to encourage you to remember is that the water's only chest deep. So at any time you can stand up and take a moment and have a radical change in perspective. And that can be a moment of dropping in mindfully, but it can also just be like really listening when one of your colleagues tells you how they're doing, or hugging somebody. I don't mean to make this ridiculously nice, but it's true. Like bringing some kindness just for a second to our interactions can have a tremendous effect. Again, small changes can result in big things because change is not linear. And so the last good news is that actually the government is getting on board with addressing these issues in private equity. And this is a shared bipartisan movement to start creating regulations to help us combat this growing issue. I won't go into unions, but those are also a tool. So think about that for yourself. In any event, thank you very much for your time. Questions? Yeah. So there's a few things that are coming out. One is coaching, because I think in some branches of surgery, they say it's more like 5 years. And I think if you were like me, I thought, I can work really hard, but it's not the physical labor, it's in here. And so we're thinking more and more about why aren't senior surgeons who have been through it all, who've seen it all, given some type of incentive to make part of their job mentoring young people so that they can scrub into the OR with you, or take you out after you're done with a case, or do the stuff that a lot of us are doing just because we know it's the right thing. But why not make it a system? There's no reason it couldn't be. So that isn't out there yet, but there's ideas about what it could be comprised of. And then we just need to figure out, how do we turn that in, how do we operationalize that? It gets harder for different reasons. Yeah. Well, that might have a lot bigger effect than you realize. But I do think that's something that we need to change in our thinking is how do we not just be individuals that are separated doing what we think is right to change the problem that we agree is happening? How do we bring that energy together and have some synergy?
I don't think we can hear the audience. Are people able to hear us on the Zoom chat?
We can hear you.
Oh, perfect.
I'm so,
Great. It's
I'm
Robin
sorry.
Lamar. That was such a
Do you,
wonderful talk. Thank you so much.
do you want to go on mic? Sure. Yeah. Okay.
A few of us in the chat were just saying your study results were so impressive. And are there any thoughts of offering ESRT as a course that other surgeons could take? It seems like there's a lot of us that might benefit from that sort of training.
Yeah, it is. It is an available course, and we have a lot of instructors. We can offer it to departments or institutions. We can train someone in your own department to be the instructor if you want to have like an embedded resource. Yes, please email me. And the other question that was coming from the audience had to do with questions about sort of the relevance or impact of this work because it's focused on individuals in a systems level problem. Yes. And you're absolutely right. So I want to make it clear that I'm not saying that a mindfulness intervention is going to fix healthcare or fix the systems we work in. Absolutely not. That's ridiculous. But what it can do is a few things. One, it can help us experience less distress while we're working in an acknowledged stressful system. It also can help us, and this is just a function, I think, of what happens on the neuroanatomic level, to think more creatively about how we want to solve these problems. What's interesting is that we've run workshops with departments of surgery at other institutions using some of these systems thinking techniques. And it's amazing how insightful people are about the real problem in their clinic or 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 pay structure or leadership hierarchy and real ways it can be fixed. And that even if you push people a little further and say, okay, for that change to happen, you're going to have to figure out how to demonstrate it's economically viable. They can even think about ways to capture the economic benefit of what they're proposing, which I imagine you guys could too. It's just that you need the forum and kind of the inspiration and then the opportunity. So I take that criticism to heart, but I also recognize that's like saying, I'm buying milk at the hardware store. It's ESRT's milk. If you need a hammer, go to the hardware store, get it there. Yes, ma'am. Yeah. Well, first of all, there are more people who are trying to delve into this and understand how it's directly affecting the work we do. And it's kind of tricky, but I have a big data set that we're working on with this. So anybody who wants to get involved with something like this, please let me know. Very happy to include people. But there's a few things we know. Many of the hospitals that are closing across the country have actually been bought out or had a majority share purchased by private equity. They sell out the land from underneath the hospital, and then the hospital has to rent the land that they exist on. And this leverages a ton of debt against the hospital system and bankrupts it. And so one of the first examples of that was Hahnemann Hospital in Philly, but it's happened again and again. And I think there's more than 30 now, just in the last, say, decade, that have closed along that exact same pattern. How the influence of private equity or private equity influence in not-for-profit hospitals is working is part of what we're trying to figure out. And I think, you know, not to be a rabble rouser, but sometimes the one way we can do something collectively is to come together as a collective, because ultimately, if we want the way things are to change, one thing we have in our toolkit is our work, the work we do. And there's a ton of excellent data out there, both about creative ways to collectively bargain that have no harm to patients at all, that allow us to still do our work, that I would also be happy to talk to people about. But I think it does take not just writing a letter to the senator, you know, and not just shopping somewhere else or other things that we do when we don't like a company or an economic system. And I think surgeons are actually one of the last groups that can do this, because all of us as a community are the economic engine of the health system. So if us and anesthesia could get together on that, I think the things that we wanted to see done would have a lot more strength behind them getting done. Yes. Okay, I'm not sure I fully understand the question. So how have I funded the work? So a lot of it has been small, like foundation grants and original startup funding from my department when I came. I was recruited under Nancy Asher, and she really just believed in taking risks like this. And so I'm grateful to her for helping me start. The NIH has only recently begun to really put out funding calls that could be answered with this kind of work. And so that's one of the reasons why I tell everyone about that AHRQ funding announcement, because I think we're going to start seeing more of that. And then in terms of how this stuff is enacted in our department, some of it is and some of it isn't. You know, we have scribes, we have APPs, you know, we have some of the other stuff that I think across UC we're trying to implement, but we don't have the true systems fixes because we don't know what those are yet. But I guess what I'm getting at is to say, maybe we can work super hard at this job and give it our all, and then have a kind of job where you get to take a break. So for instance, in Scandinavia, if you're a physician, every 5 years you have to take a sabbatical. And it's 6 months long, and for 3 of those months you have to do something scholarly to like enrich your knowledge, not just CME, but like maybe some body work. And for 3 months you have to do just nothing. Because they get it, right? Like you can't do it month after month, year after year, and not fall apart in some way. So this talk is meant less to say all the answers are out there, but more to say we're trying to bring together resources and brains and willingness to start coming up with truly effective changes, and then hopefully get support from the surgery community behind these things, so that as a community we can push for these changes. But it's definitely not an on-off type of solution. It's going to take more than that. Yeah.